Hi, everyone. Thanks for tuning into our podcast. My name is Patrick.
I'm Taz.
I'm Preeti.
I'm Emma.
I'm Harika.
Today, we're going to be talking about changes in the U.S. healthcare system in the last 20 years. More specifically, we're going to be asking questions such as, what has changed, what works, and what doesn't? Let's dive right in. It's the year 1990. Jane Doe is a 25-year-old living in rural Mississippi who has started to feel nausea and general malaise recently, but doesn't know what to do. She thinks she's late on her period, but she's not sure. She asks her friends and neighbors for their opinion, but they aren't familiar with her symptoms. She's currently in between jobs and doesn't have health insurance, so when her symptoms get worse, she goes to a walk-in clinic for a checkup. When she arrives, the receptionist has her sign in on a paper sign-in sheet and asks her to wait until her name is called. Jane waits 2 hours for her turn, feeling worse the entire time. The nurse finally calls her by name and says loudly to her in the waiting room, "You don't look so good. Are you going to throw up?" When she's given a paper form to fill out, Jane tells the nurse that she has previously been seen at this clinic. The nurse spends 15 minutes searching through the file cabinets in the back room and comes back to inform Jane that her records must have been lost the last time the clinic reorganized their records. As the nurse leads Jane back to the examination room, Jane notices her friend Franny's chart on a table. Jane will see Franny's brother on the walk home later that day, so she makes a note to ask him if Franny's feeling okay. Once in her exam room, she explains her situation to the doctor and mentions that she thinks she might be a few days late on her period, but she's not sure. The doctor suspects that Jane is pregnant, so he draws some blood and tells Jane to come back later in the week for the results. The doctor forgets to ask Jane, however, if she's taking any medication, and Jane doesn't mention that she often takes painkillers for her headaches and some other unspecified pill for random flares of acne. Jane leaves the clinic worried because she is pregnant, unemployed, and has no health insurance.
Next, we will discuss a timeline of important healthcare events. Our timeline begins in the year 1960. The Mayo Clinic in Rochester, Minnesota was one of the first major health systems to adopt an EHR.
A few years later, in 1965, President Lyndon Johnson signed into law the Medicare program, which provided medical insurance for Americans aged 65 or older, as well as Medicaid, which offered health coverage to certain low-income people. Around this time, the federal government also implemented an EHR in the Department of Veteran Affairs, a system which would eventually become VISTA.
Then came the Consolidated Omnibus Budget Reconciliation Act of 1986. It allowed employees who lost their jobs to continue with their health plan for 18 months.
A year later, in 1987, Health Level 7, HL7, was founded to address standardization issues as EHR development pushed forward. And then in 1996, the Health Insurance Portability and Accountability Act, HIPAA, came about, doing two major things. One, it restricted use of pre-existing conditions in health insurance coverage determinations, and two, it set standards for medical records privacy.
At the turn of the century, the Da Vinci system was approved by the FDA. This revolutionary system was the first instance of widely adopted robot-assisted laparoscopic surgery.
In 2008, Google Health was created to allow users to consolidate their self-reported health information into their own centralized Google Health profile. This program was discontinued in 2011.
In 2009, the American Reinvestment and Recovery Act, ARRA, makes substantial investments to help develop health IT and treatment options. An important component of the ARRA was the HITECH Act, which was signed into law to promote the adoption and meaningful use of health IT.
In the same year, the Children's Health Insurance Program, or CHIP, was reauthorized, providing states with additional funding, new tools, and fiscal incentives to help reach an estimated 4.1 million uninsured children by 2013.
In the second year of his presidency, President Obama signed the landmark legislation, the Patient Protection and Affordable Care Act, also known as Obamacare or the ACA. We'll talk about that later on.
In 2012, the Genetic Testing Registry was formed to provide a central location for voluntary submission of genetic test information by providers. The overarching goal of the registry was to advance public health and research into the genetic basis of health and disease.
In 2014, the first version of FHIR, also known as the Fast Healthcare Interoperability Resources, was released. One of its goals was to facilitate interoperation between healthcare systems on a wide variety of devices.
In the same year, the NIH's BD2K initiative, or Big Data to Knowledge, entered its first phase, investing $200 million in grant awards to address some major data science challenges and to stimulate data-driven discovery. BD2K has now entered a second phase that will focus on making the products of research developed in Phase 1 usable, discoverable, and disseminated to their intended end users.
Last year, Stanford University created an artificial intelligence that was trained to classify skin lesion images as benign or cancerous, achieving the accuracy of board-certified dermatologists.
And now, in 2018, DeepMind AI is not only able to automatically detect the features of eye diseases in seconds, but can also prioritize patients most in need of urgent care.
Let's talk more about the Affordable Care Act that we mentioned in the timeline. The ACA was passed in 2010 for two main reasons. One, it provided subsidies for people who could not afford health insurance. 2, it mandated insurance for everyone, so cost of coverage spread across the whole population. In the present day, Americans face higher health insurance premiums and copays, higher deductibles in health plans, and extraordinary high prescription drug costs. However, since the passing of the ACA, millions of Americans are now have coverage, which is indirectly reducing the cost of healthcare. Let's talk about the positives and the negatives of the ACA. The biggest benefit of the ACA is that it slows the rise of healthcare costs. It also requires all insurance plans to cover 10 essential health benefits. This includes treatments for mental health, addiction, and chronic disease. Insurance companies can no longer deny anyone coverage for pre-existing conditions. Children can stay in their parents' healthcare insurance until they're 26, which is good for us. Now let's talk about the negatives of the ACA. 3 to 5 million people lost their employment-based health insurance because many businesses found it more cost-effective to pay for the penalty and let their employees purchase their own insurance plans on the ACA's exchange. Also, prescription drug spending soared due to high copays and deductibles. 30 million people never had company plans and therefore relied on private health insurance. However, some private companies had to cancel these plans because their policies did not cover the ACA's 10 essential benefits. The ACA also taxed people who didn't get health insurance. Finally, in 2013, the ACA raised income taxes for 1 million people with incomes over $200,000.
The ACA has now made healthcare more affordable in the sense that someone else, either Medicaid or a private insurance company, is now paying for the majority of bills, but medical bills themselves have not decreased in cost. The ACA has also reduced the price of drugs to consumers, but not the unit price itself. This way, medications have become more affordable despite the increased unit price. Why is the cost of healthcare still so expensive in the US? Well, our physicians take advantage of every drug, every treatment, and every technological advancement to help their patients. Compared to other countries, we don't visit our physicians as frequently, but the quality of care and technological advancements have increased the price of healthcare.
Now, let's go into more detail and talk specifically about the 10 titles of the ACA and how they changed healthcare. Title I required insurance plans to cover ER services, including outpatient care, lab tests, maternity and pediatric care, mental and behavioral health treatments, prescription drugs, and those with disabilities or chronic conditions. Title II extended Medicare and passed the CHIP Act, which provided coverage to children and those who could not afford it. Title III closed the gap in prescription drug coverage. Title IV focused on tobacco-free living, preventing drug abuse, living a healthy lifestyle along with reproductive, mental, and emotional health. Title V funded scholarships and loans to increase the number of primary care physicians, nurses, PAs, mental health specialists, and dentists. Title VI required doctors to report any financial interest with companies and vice versa. Title VII provided drug discounts to hospitals that served low-income patients. Title VIII was passed to financially assist Americans who were physically challenged. Title IX raised Medicare taxes to people with high household incomes. And Title X modernized healthcare for almost 2 million Native Americans.
So I went to medical school at Ohio State, and then I did my general surgery residency at Cleveland Clinic and stayed there for my vascular surgery fellowship, and then came back to private practice from my residency into a private practice hospital here in Columbus, and was there for about 9 years, and I practiced at Ohio State for the last 14 years. So when I was a medical student and a surgery resident, we didn't have electronic health records, so everything was done on paper, orders, and patient notes, which made it probably quicker to take care of patients, but it also made it less convenient. So to look up medical records, we had to go to a central medical records facility within the hospital. X-rays were not on a computer, so we had to run around the night before surgery finding X-rays, which were a lot of times sent from the outside or spent time in a file room, which is where the X-rays were stored. So it certainly makes things a lot more convenient today and easier to look up and take care of patients and compare things to the past, but it also makes it quite a bit slower. So one of the changes in the operating room is obviously the electronic health records as well, because it makes the nurses recording, although lengthier, makes it easier and again easier to look things up that have happened in past surgeries. Anesthesia as well has their documentation system much easier to record how patient's doing during surgery. For my specialty, vascular surgery, we have a lot of new technology when it comes to devices that we can use to make surgeries much less invasive than they used to be. We use a lot of X-ray type procedures, or what we call endovascular procedures, where we repair arteries from the inside instead of larger open operations. Well, the Affordable Care Act is obviously a very complicated document, obviously written by lawyers and legal folks in Congress. So it's hard as a physician to get our head around all that it involves. The things that probably affect me that I see are that patients do tend to come with insurance more so than they had in the past. However, the process for physicians to maneuver through the new requirements of us are much more onerous when it comes to reporting, dealing with insurance and getting things paid for, just record keeping, just little details that I think a lot of physicians don't think is as important nor affects patient safety, but now we're required to do that in order to get reimbursed. Ideally in the future, although it started to happen a bit, is that our electronic medical records will speak with one another. So I can now understand what my patient had done at another hospital up the road. It would be ideal if all the different brands of electronic medical records would speak to one another. Then we might have better access. Patients already think that happens, but it doesn't happen very smoothly. When it comes to our electronic health records, it would be ideal if everybody had some kind of device on them that would give their medical history, allergies, medications they're on. Certainly that would make things universally safer. I know there's always concerns about privacy, but that would be ideal.
All right, everyone. So we've had a pretty good discussion about the changes that have occurred in healthcare in the past couple of decades. So let's wrap things up with the story of Lisa, who is experiencing symptoms that are much like those of Jane Doe, about whom Patrick talked about earlier, except this time it's the year 2018, and a lot has changed. So Lisa's been feeling nauseated and weak for a couple of days, and she decides to do a quick Google search of her symptoms. A couple of quizzes that she takes online suggest that she might be pregnant. So she checks the period tracker app on her phone, and she goes to the drugstore and buys a pregnancy test, and a faint line there, as well as the app, confirms that maybe she might be pregnant. So she immediately makes a next day appointment with her primary care provider on this very convenient online scheduling portal. And when she gets there, the receptionist checks her in with one swipe of an insurance card. Thankfully, her work covers her insurance, and she has a very low copay. So she's waiting in the waiting room, and she's been given a ticket number so that when the doctor's ready for her, she can come in and very discreetly call Lisa in. And when they get back to the examination room, the doctor makes sure to ask Lisa to confirm her name and her date of birth, because she wants to make sure that it is Lisa's record that she has up on her computer. The doctor skims through the electronic medical record, and she's able to make sure that there aren't any pre-existing conditions that are making Lisa feel the way she's feeling now. So the doctor feels like she has a pretty good idea what's going on with Lisa, pregnancy, but the doctor does appreciate it when the computer prompts her to ask Lisa if she's had any unprotected sex recently. And when Lisa says yes, the doctor is able to very confidently go ahead and order a blood test. And while putting in the order for the blood test, the EMR also bings her with a notification that Lisa had been prescribed with some medication for migraines and acne. Having those while pregnant would be bad for the fetus, so the doctor is able to let Lisa know to stop taking those just in case she's pregnant. So before Lisa leaves, the doctor sets up an automatic reminder to let Lisa know to come in when the blood test is ready. Yeah, so we've had a really great time researching the journey of healthcare through the past couple of decades for this podcast, and we hope that you all found it as informative as we did. Thanks.